The spotlight on emerging immunopharmacology for controlling rheumatic and allergic diseases. So I'm Masaru Ishii from Osaka University, Japan, and an executive committee member of immunopharmacology, so the immunopharmacology section of IUPHA. So on behalf of the immunopharmacology section, so I'm happy to organize and chair of this session. So let's start from the first speaker. So yes, first speaker is Professor Stefan Siebert from the University of Glasgow. So he's talking about recent advances in therapeutics for rheumatoid arthritis and spondylarthritis. So, please, thank you.
So that's working. Thank you very much for inviting me, to the organizers as well, for inviting me to speak. I've just come down the road, so I haven't come far. Those are my disclosures, and I'm obviously work in Glasgow, so I hope you're having a great time during your conference here in the city. Just to be clear, these are my slides and not influenced by anyone else. So I've been asked to give an update on advances for therapeutics for this area, and I'm a clinical academic, so instead of just giving you a long list of potential targets, many of which you will know and may not be relevant to you, I thought I'd just take a broader, high-level overview of where we are with our therapeutics in this area, what we've learned, and actually what these therapeutics have taught us as well about our diseases, and maybe the way we want to treat them in future. I will focus on biologic therapies, particularly cytokine inhibitors, because that's what's dominated our field. But I'll be talking about other strategies as well, and as I said, where we could be going. So I'm going to talk about two main disease groups or diseases, rheumatoid arthritis, which to me is a systemic inflammatory disease that happens to affect the joints. So it's dominated by systemic inflammation. And actually, I think it's dominated our thinking in this field to the detriment of other diseases. And I'll be talking about spondylarthritis in general, but psoriatic arthritis specifically. So that's an immune-mediated inflammatory arthritis, but affecting multiple domains. And I would argue that more of the problem is at the local tissue level rather than just systemic inflammation. So it's just worth thinking about where we came from. So I'm old enough to remember when rheumatology was a rehab specialty. We used to have up to 100 inpatient beds where we basically gave corticosteroids and rehab to patients. I had weekly meetings with the hand surgeons, and the outcomes for our patients were terrible, and they had high mortality related to their inflammatory rheumatoid arthritis. And two big things happened. The one is that we got a much more detailed understanding of the underlying biology of inflammation and inflammation in these diseases. So we had logical targets to go after, and that remains the case now, but we realize how much better we need to understand that. And the other thing that happened, and it's easy to forget about, is the technological advances really in the way of monoclonal antibody development. And even, the development of the delivery devices, because when I was, everyone was saying, how can patients with rheumatoid arthritis who have functionally disabled hands ever inject themselves? And I think we forget how much development happened in that field. But luckily, we've had these advances, and actually, it's a completely different specialty. We're driven by immunology, we're interested in it, and we chase it. We are an outpatient specialty. Our patients very rarely get into hospital for their disease. They get there for other problems, but not their disease as often. Our treatment's dominated by biologics and increasingly biosimilar drugs, which cut the cost and allow us to treat more. And the other thing that's changed is because we've got effective therapies, we now treat to targets. We don't accept ongoing low-grade inflammation. And I think our next step is going to be to take the targets beyond that. And obviously, the outcomes are much better for our patients. And I've said a lot of this, but really, we've gone from steroid-driven disease to broad-spectrum immunomodulators, where we didn't really understand the mechanism, to targeted therapies, initially biologic agents, and subsequently small molecule inhibitors. And the other thing that's had to change, and I think is going to have to change again, is the way we do clinical trials in order to address the questions we are asking fit for the therapeutics we have available. And so the fortunate thing in clinic now is that I can, I can inhibit the immune system in a patient with rheumatoid arthritis on multiple levels, from co-stimulation down to inhibiting B cells, getting the effector cytokines IL-6 and TNF-alpha, and increasingly intracellular molecules. And this is a slide I use for teaching. The depressing thing is in the last 3 or 4 years, the only thing I've had to change is the date. So I think we are due for some new therapies and maybe a paradigm shift in rheumatoid arthritis. And I've already suggested this, that rheumatoid arthritis isn't the only type of inflammatory arthritis, and we have these other immune-mediated diseases. We've clumped these together since the 1970s because we know patients overlap in terms of family members and have multiple conditions. And these conditions clearly are not rheumatoid with a rash, and they include things like psoriasis, inflammatory bowel disease, and uveitis. And in addition to these extra articular manifestations, many of them at barrier sites, you'll realize, the arthritis is also different. It's much more localized rather than systemic. It's at areas of biomechanical stress leading to enthesitis. It's in the spine, which rheumatoid doesn't really involve. And these patients, in addition to getting damage, the erosive disease we see in rheumatoid, they get new bone formation. And clearly, these are quite different diseases. And you'll see how it's taken us a while to move on from treating them other than rheumatoid. And their genetics and immunopathology is dominated by dysfunction of innate immunity, again, and barrier function. So again, fitting with the other extra-articular areas involved. And you know this, and we found that TNF was central to all of these diseases, and inhibiting TNF-alpha, it was high in all of these diseases I've just shown you, the spondylarthritis, and inhibiting TNF-alpha, because it's so central, was effective in all of these conditions. So I think we got a little bit lucky and therefore a little bit lazy, but actually, interestingly, inhibiting IL-6, which is also increased in these conditions, has been less successful. The other thing is these patients don't stay on their TNF inhibitors very long. About 50% of them will be coming off or switching their drug within 4 to 5 years for a variety of reasons. So clearly there was a need for other targets. And the fortunate thing is we have advanced our understanding of the disease, and particularly the IL-23/17 pathway has dominated this field. It is the dominant pathway in the skin and in the bowel as well. And increasingly, and it's been harder to show, in the enthesial sites, so in the areas of biomechanical stress, there are IL-23 responsive cells. We called them Th17 initially, but let's call them type 17 because there's a lot of other cells beyond T helper cells in there. And they make cytokines that allowed us to sort of draw this line from the pathophysiology, the genetics, the barrier function, all the way to the arthritis. And I'm just to highlight, so we've got a regulator and an effector cytokine down there, and that you'll see why that's relevant later. It was interesting to speculate why there should be immune cells here, because clearly we need them at the gut and the skin, but actually it's very unlikely to get infection at an enthesial site. So it's interesting to speculate why they're there, and the answer has to be to deal with biomechanical damage. And this is the figure, what spondylarthritis looks like in the clinic, inhibiting this pathway. And obviously TNF, you could have put it on either side really. Inhibitors work in parts because they inhibit this pathway. But I'm going to focus particularly on the IL-23 and IL-17, so the regulator and the effector cytokines in this pathway, and what we've learned from these. And so IL-17's increased in rheumatoid arthritis as well. But interestingly, the study didn't meet its primary endpoint. There's a signal for benefits, but actually it didn't reach its primary endpoint. And I think in part because TNF is so dominant in rheumatoid arthritis in the systemic inflammation. But actually inhibiting IL-23, whichever way you do it, and inhibiting IL-17 in the skin is spectacular. They've had to change their outcome measure because just going for a low hurdle isn't good enough. You want 90 to 100% clearance. And even that is probably not sensitive enough to catch that. So the results in the skin are spectacular. In the joints, these are highly effective in psoriatic arthritis, but probably no better or different than what we see with TNF inhibitors. So we're getting quite a mixed biological picture coming out across the spectrum of inflammatory arthritis. And if we just stick to the IL-23 pathway, what's really interesting is it does seem to matter where you inhibit this pathway. So in the skin, we've had this hierarchy that 23 inhibitors, especially P19 and IL-17, are better than inhibiting 23 by P40, and they are much better than TNF. So the pharma companies are delighted to do head-to-head studies because this pathway is dominant in the skin. But what's interesting is even if you take the same pathway, so inhibit IL-23 with guselkumab and you inhibit IL-17 with secukinumab in the skin, this is psoriasis, what you see is that in the first 16 weeks, inhibiting the effector cytokine IL-17 seems to work better or quicker. But actually, once you get beyond that point, it seems like inhibiting the regulator may be a better effect than just keep hitting the effector cytokine. So there does seem to be a dynamic change that happens to the immune system in response to treatment. And we're starting to unravel that in that there are studies now of skin biopsies. That's the good thing. It's very easy to get skin, showing that actually what changed while all immune cells go down when you treat with guselkumab or secukinumab, so 23 or 17 inhibition reduces inflammation in the skin. We know that the patients get better. But what's really interesting is the types of cells that change. So guselkumab, the IL-23 inhibition, reduces your T-resident memory cells without affecting your T-regulator cells, whereas secukinumab has the reverse effect. It doesn't seem to reduce the T-resident memory cells. So in other words, the implication being it gets rid of inflammation, but it doesn't change the memory and the chronicity of the inflammation. So you can see that where you inhibit on the pathway may matter, and I don't think we know how to do that properly yet. In psoriatic arthritis, we've only got 2 head-to-head studies, which again tells you there's not a big difference. This is just a comparison of IL-17 inhibition to TNF inhibition, and they had this really unique, novel endpoint. It's never been used in a trial before. High hurdle, ACR 50, 50% improvement in the joints, and 100% improvement in the skin. And they said, look, inhibiting 17 is better in psoriatic arthritis for this endpoint than TNF. But actually, if you look at the data separately, it's much better in the skin. But we knew that. The skin is a 17-20 or 23-17 disease. But actually, in the joints, there isn't really much difference. So the picture in the joint seems to be a lot more mixed than what we see in the skin. So I've been focusing on inhibiting 23 and 17 on the same pathway. But what about, does it matter how we inhibit IL-23? And IL-23 is made of 2 subunits. The P40 subunit is shared with IL-12, so it signals through both. So drugs that hit both pathways. Whereas P19 is unique to IL-23, and there's a number of P19 inhibitors. And we know that in psoriasis and possibly psoriatic arthritis, there's a definite hierarchy here. But what's interesting is that it seems to matter to the effector cytokines as well. So this is work we've done using the clinical trial data showing that both drugs reduce CRP, so inflammation, equally, but actually it looks like the effect on IL-17, so the downstream effector cytokine is much greater with a P19 inhibitor than a P40 inhibitor. So it seems to matter where you inhibit on the pathway. It seems to matter which subunit you inhibit on IL-23. And actually, if we just look at P19 inhibitors, there seems to be a difference as well. We've had the signal that 2 of them have a slightly different effect in the skin. And one of the theories that's coming out is that these CD64 cells, which are present in the skin, in the gut, in the joints, seem to be key producers of IL-23. And guselkumab is a fully human monoclonal antibody with a native Fc region, so it can bind to these cells, whereas risankizumab is a humanized antibody with a mutated Fc region, and they've shown that it cannot bind to these cells. So it seems like not only does it matter which subunit, but how you inhibit that subunit in terms of the effect. And all of this is information that will help us design better drugs in future. So if we take a step down to the IL-17 level, the effector cytokine level, sorry, I noticed just before I came in that one of them is left. So it's a superfamily. There's 6 and not 5 subunits, and there's cytokines and 5 receptors. And some of our drugs inhibit IL-17A, and they work brilliantly for the skin, quite well for psoriatic arthritis. But actually, we've also got drugs coming now, such as the dual-specific bimekizumab, which inhibits A and F. So A is the dominant cytokine in this family, but actually F seems to have additional pathogenic roles. And so you can already see that there may be differences in what's happening efficacy-wise, but more importantly, biology-wise. And we've got drugs that inhibit the IL-17 receptor, which is shared by the entire superfamily. And again, people might say, oh, the more you inhibit, the better. But actually, it matters where you inhibit as well, because we don't know where all of the sites for these inhibitors are. So I guess what I'm showing you is that we've moved from understanding pathways to understanding what do we need to hit in this pathway to make the real difference downstream and change these diseases. And having these tools, these molecular scalpels, effectively allows us to examine some of that. So I've been talking in this domain here, but what about axial spondyloarthritis and inflammatory bowel disease? 1723 pathway dominant. What happened in the trials? And the answer is we got surprises in that IL-23 inhibition seems to work really well for Crohn's disease, but IL-17 studies were stopped because their bowel disease got worse. And what we've learned, and we should have known at the time, was that IL-23 independent IL-17 is required to maintain barrier function. So it affects occludin. So you inhibit that, and suddenly your bowel's more leaky. The other surprise we got is that axial spondyloarthritis, so the spinal involvement, IL-17 works, but actually IL-23 does not work. And this is still not fully understood. But again, there seems to be an IL-23 independent pathway going on in the spinal disease. So the message here is just because a cytokine seems to be implicated, it doesn't mean that inhibiting it works, and we need to do the trials. And then we need to understand why the trials didn't work. So we've got this hierarchy emerging that's showing just measuring something's there, just saying it's pathogenic is not good enough. We need to do the studies and then understand the biology. And actually, you know, did we really expect the same cytokine to be doing the same thing in different tissues? Because these cytokines haven't evolved to cause disease. They've evolved to maintain infection, to control infection. And in the skin, you're really worried about fungal infection. So 17 is dominant there. The gut, you've got bacterial, lots of bacteria and immune homeostasis. So you've got different cytokine processes. And the same process in these sites and eye is probably just involved in biomechanics, so sensing damage from tissue. So you use your immune cells to sense damage. It's not there to sense infection. So we shouldn't have been surprised that there are tissue-specific effects in the same disease, in the same patient. And so I've been talking about single cytokine inhibitors, and I think the next step we're moving to is you're already seeing that the dual-specific, do we want to inhibit two cytokines at the same time? And the experience with combination biologics has actually been quite bad in rheumatoid, and what we seem to learn is that if you inhibit the same pathway, TNF and IL-1, you just get more side effects without getting more benefits. But that's in a systemic inflammatory disease. These two, TNF and IL-17, are synergistic, so people are trying inhibiting them both, and there's a bit of a signal, but again, there isn't a big signal of benefit over slight increased side effects, so we seem to be coming with a cost for dual inhibition. Psoriatic arthritis is clearly more tempting. You've got different tissues, different domains, so I've certainly got some patients on combination biologics where I need the one for their skin and the one for their joints because I cannot control with both. And it does look like, you know, that it doesn't look like the low hurdle responses improve. So that's a 20% improvement, that's a 50 and 70. But it seems like, so not more people don't seem to improve, but actually the people who do improve seem to improve better. So we may need combinations to achieve better outcomes in the people who are going to respond. And I think we need to revisit this entire field of induction and maintenance, sort of the cancer model. Can we hit these diseases hard early on and then use different treatments to maintain their control longer? And I think we're going to need to do very different studies. And to be honest, in the past, we didn't have the drugs or the tools to do that, but now we do, and I think we as an academic community need to be doing those studies. The other point is maybe we've used the wrong combinations, and maybe if we had a regulator and an effector instead of two effector cytokines like TNF and IL-17. And there's really promising data from this study in ulcerative colitis coming out saying that if you inhibit IL-23 and TNF, you get better outcomes in the gut in ulcerative colitis. And again, the psoriatic arthritis study is going on. And the 23 inhibitors really have got a good safety profile. So we have got options for combination there that we maybe didn't have. There's this question about sequential. Should we be blocking A and then B? And we don't know is the answer. This is an intriguing case series of 3 patients from Georg Schett's group in Erlangen, where they failed to respond in every domain to TNF, IL-17, 23 monotherapy. But when they alternated 1 month of guselkumab, so 23 inhibition, 1 month of 17 inhibition, and then back to 23, every domain improved. So a small case series, but it's intriguing that actually maybe we need to be doing these sort of studies. It's also questionable whether this is truly sequential or whether the pharmacokinetics mean it's actually a form of combination therapy. So everything I've talked about is here, extracellular. I'm going to just finish off by talking intracellular as well, because clearly, once we know what cells are involved, we can start targeting intracellular processes rather than just extracellular proteins. And this field's been led by the JAK inhibitors. So you've got cleverly named JAK1, 2, 3, and TYK2. So they're the 4 members. And they are licensed for a number of diseases and where they've shown efficacy. Less so in the skin, but again, the skin you're competing against 90, 100% clearance with 17 and 23. And I didn't want to show a lot of safety data, but our field, every conference you go to is full of this oral surveillance study. So this is an FDA-mandated phase 3b/4 safety study, non-inferiority, done in patients because of this concern about a cardiovascular signal. So remember, our patients with rheumatoid arthritis get more cardiovascular disease because they've got a pro-inflammatory state. And everything that shows is actually when we treat the inflammation, that usually goes down. And we've definitely reduced mortality in rheumatoid arthritis with TNF inhibitors. So this study is randomizing patients to 2 doses of tofacitinib, and the control arm is TNF. And these are people who are over 50 with 1 or more cardiovascular risk factor. And actually, the JAK inhibitor, tofacitinib, did not meet its non-inferiority cutoff, which is a 1.8 cutoff at the upper limit of the confidence intervals. So again, this is for major cardiovascular events and for cancers. So the one thing that worries the regulators is we don't understand the full mechanism of this. But, so this study is ongoing. But as you can imagine, there's been a lot of post hoc analysis of these data. And what it's showing is that actually these major cardiovascular events are driven by a small group of patients. And these are the people who've had a previous coronary event, cerebrovascular event, or peripheral artery disease. They are driving the risk of having future events, whereas it's much lower in those who've never had an event. And in fact, the number needed to harm in 5 years with someone with a history of a cardiovascular event who gets this JAK inhibitor is 16. Whereas for the ones who've never had a history, it's between 223 for the combination and 800 for the lower dose. So you can see that something is happening in people who've had previous cardiovascular diseases and how they separate. What's really interesting is the cancer risk seems to follow this risk as well, again suggesting that there's a shared mechanism between what's relating to the cancer risk with tofacitinib as well as the cardiovascular risk. So the JAK inhibitors aren't all the same, and tofacitinib is a very non-selective JAK inhibitor, and we've moved all the way down to increasing selective ones. But TYK2 is a really interesting target. One, it's downstream of IL-12, 23 interferon, so you can see why in spondyloarthritis it's really tempting to inhibit that. And the other thing is that TYK2 is very different because it's an allosteric inhibitor, so it doesn't bind to the active site like all the other JAK inhibitors do. It's binding and making the kinase inactive, at binding at a pseudokinase site. So I think that we may move away from this concern about cardiovascular and move to more targeted and more rational JAK inhibition. So I just want to say we've moved away from this we're moving away from this organ-based thinking of inflammatory mediated diseases to thinking about a molecular signature. And ultimately, that would be the ideal way to call it. Who cares if I think it's rheumatoid or psoriatic arthritis? If the signature is X, let's treat X, And so, but what's happening, and I think what complicates this field, is that we're understanding that in the tissue, there are very small populations of cells that are causing a lot of the problems. So I've already said to you that spondylarthritis isn't really a systemic illness, it's a local problem. And maybe we need to be looking more tissue-based. And thinking of that, and this is back to rheumatoid, at the moment we've gotten very good at treating people with established rheumatoid arthritis who've got active disease. We're less good at remission, and we certainly are not good at the cure and prevention side yet. And that is what our patients are demanding of us and what we need as the next treatments. So I just want to finish off thinking about some of that. So it's interesting whether actually the way do I change someone's disease by giving them a TNF inhibitor first before CD20 inhibitor? It's a good question, and sadly it's one we don't know. But what we do know is that even when we control patients, are they really in immune remission? Have we got them in remission? And it's interesting thing, so why do we never cure these patients? And there's a number of things that keep chronicity of going on the joint. Once it's inflamed, there's also damage and cell trafficking and the stroma. And at the moment, we target very few aspects. Really, the infiltrating immune system is what we treat when we treat rheumatoid arthritis. And there's a lot of interest in our field in dealing with stromal disease and thinking about what the environment affects how the immune cells act. I think that's clear. And also, can we really cause repair until we get that? And I know there's a talk later on about repair as well. The other thing that we're doing much more is we're saying we have to go to the tissue, and we're having biopsy-driven studies, and this has been led by Kos Pitsalis in London, showing that actually there's different pathotypes, and we're starting to do stratified trials by saying, if someone's got poorly immune, should we really be giving them an anti-cytokine inhibitor, or are there better treatments that we might want to give this group compared to this group with lots of myeloid cells? And the way we think about remission, we thought about clinical remission, the patient feels well, their joints aren't swollen. To imaging, there's no inflammation imaging. I think we need to move towards immunological remission. So in other words, have we reset the immune system in the tissue site? And I haven't got time to talk to you about fibroblasts, but it's very clear that the fibroblasts in the synovium seem to be key, and our colleague Mariola Koroska-Stolarska has shown nice work showing actually what has to happen to the fibroblasts to induce remission in rheumatoid arthritis. So if we can understand that, we can start targeting and moving towards that. So the last bit is just finishing at the start of the disease, because everything here is just recovery and trying to undo things. Can we prevent disease happening? And we've always talked about this window of opportunity in rheumatoid arthritis, saying treat early, and there's no doubt that's changed a lot of management. Treating early instead of waiting for damage has changed outcomes on its own, regardless of any drugs. But every time you get inflammation, you accrue damage, and you probably can't reverse that. But I would argue that even on an immune system level, there's probably a tipping point where you go beyond it and you can't reverse that immunological dysfunction, whatever that is, and we need to understand that. And there's a lot of studies going on now in this term, AURA, people at risk of rheumatoid arthritis. And clearly there's a lot of targets. Again, a lot of them are focused on the adaptive immune system still. So that's partly because of the tools we've got, but partly, and the way we think, and we've been looking at the immune system. But I would argue that maybe we need to move to other things, including tolerance, really. And these are two papers that have come out in the last year looking at, can we treat people with symptoms and at risk of rheumatoid and prevent rheumatoid arthritis? And there was an early rituximab study, and last year there's a methotrexate. They got methotrexate in a single dose of steroid injection. And actually they showed that they didn't reduce the number of patients who developed rheumatoid arthritis. But they had only a third of patients were ACPA positive, so their chance of getting rheumatoid was pretty low. So showing a difference was challenging, unlikely. What's really interesting is actually that despite not showing a difference in terms of function and pain, there was a significant difference between the methotrexate and placebo group in people who don't have rheumatoid yet. So in other words, confirming the principle that in that early phase, immune inhibition, immune modulation can prevent symptoms, suggesting the symptoms are related to inflammation rather than other factors. And this is a study, and apologies, this was shown at EULAR last month, that's showing that we've been involved with ACPA, where they're looking using abatacept, so co-stimulation in people who are ACPA positive, so high risk of developing rheumatoid, and they were treated for a year, and you can see at a year, only 6% in the abatacept group met their criteria for rheumatoid, let's call it that, and a third in the people who got placebo, and even at 2 years where they had no treatment, the two arms had come closer together, but there was still a difference. And again, saying that if we can identify who is really at risk of rheumatoid arthritis here, and we can understand the mechanism, we may be able to prevent the disease, at least not end there. And my last slide is just to remind you and me that the immune system doesn't exist in isolation. It's involved with other aspects. It's involved in the environment. It's dealing with paraneoplastic system. And there are nice studies going on looking at vagus and splenic nerve stimulation to try and control inflammatory disease, and implantable devices to say, can we switch these on and off and actually control how the immune response is going? Spondylarthritis, the gut is key to that, so using fecal transplant to try and change the microbiome is an obvious thing to do to try and prevent and even treat disease, and the initial studies are looking promising. So I'm going to finish there just to say that there have been major advances. We've understood the disease, but actually the therapies, there's a sort of bench to bedside and back again retro-translational thing going on. They've taught us about these diseases, and we need to be better at understanding and taking those lessons forward. There's still a lot of unmet need. The skin, our results are 90, 100%. In the joints, 20% of patients get 60% improvement, or 60% of patients get 20% improvement. It's the other way around as well. So we still got very low bars. We need to optimize existing therapies and the way we use them. We need new therapies that actually target in the tissues. We need to work at prevention and cure. We can't just treat inflammation lifelong and try and maintain that. We need repair as well. And I guess the key message for people developing drugs is just knowing something's implicated and increased in disease and present doesn't mean it's going to work as a therapeutic target. I think we all know that, but we need to understand functional networks at a tissue level as well. And to deal with that, we need to change the way we do trials so that we can actually be looking for what is the best way to do a pre-RA study. I think we're still doing them the wrong way. What's the best way to do stratified studies and really understand these diseases and use the tools we've got at hand. So thank you for listening, and I'm happy to take any questions.
Okay, thank you, Dr. Professor Siebert. So for overviewing the current treatment against rheumatoid arthritis and also spondylarthritis, and also so you also show the future therapy against rheumatoid arthritis. So are there any questions from the floor? Yeah, please.
Hi, Stefan. That was a lovely presentation. You mentioned that obviously these cytokines and mediators have evolved to deal with infection. Is there a danger of, stopping all these cytokines with escalating drugs and different drugs that you're going to increase the risk of infection? And have you seen that in any of these trials?
So the answer is yes and yes. So we've absolutely seen it. So we learned about TB, how important TNF was maintaining granulomas in TB by inhibiting TNF alpha. So we've learned that, and there's no doubt for the JAK inhibitors, the virus, the viral loads, herpes, and the other virus shingles go up. So we learn about the infection risk as well. But I think what's interesting is I think we got lucky with TNF, because if you totally block TNF, we'd have overwhelming sepsis. And I think it shows how little we do inhibit these pathways. And you don't have to block the pathway, you just have to reduce it. And I think that's why when you inhibit TNF and IL-1, you just get more side effects, because you're blocking the same pathway higher. So I think we don't know where is that level, how much do you want to turn that dial? And with the cytokine inhibitors, we didn't really have a choice. You got what you got. But actually, if we can understand that on a tissue level, we can really hit whatever the protein is in the tissue much harder, leaving the rest of the organism, the human, alone. And so I think we can get a lot cleverer there. But you're right, just more of the same is just more of the same. And that is what it should be doing.
Thanks.
So please,
Yes, François from University Hospital of Lausanne. I would have two questions regarding JAK inhibitors. The first one is whether pharmacogenomics could provide insights into, for instance, TYK2 or JAK2, just to select a subgroup of patients who might benefit from these JAK inhibitors and limit the risk of infection or cardiovascular disease. And the second question would be, how could we explain that normally cardiovascular risk factors are associated with inflammation, and if we contain inflammation, there is paradoxically an increased risk of MACE, for instance?
So two questions, yeah. So the JAK inhibitor one, I think we've got two strategies. The one is, you can make the JAK inhibitor more selective, and the higher generations have got better. I'm not convinced we'll see this cardiovascular signal with TYK2. Pharmacogenomics has been pretty disappointing in our field. One is the outcomes are soft. Pain, there's lots of reasons for pain. So it's quite hard to, it's not like cancer. Cancer is more binary. Cancer's there, cancer's gone. So doing pharmacogenomics is difficult. But also, I think a lot of the problems at a tissue level, So I think we'll get some of the way to stratifying with pharmacogenomics, but I think that we're going to need to understand other levels of the disease much more. The immune system is so subtle that it's not going to be as binary as we'd like it to be. The cardiovascular, so it's my view, and again, it's hard to do in observational studies because the people who get biologics have got the worst disease, therefore the most cardiovascular risk. But I think there's no doubt that if you reduce the excess inflammation in rheumatoid arthritis, the cardiovascular risk goes down for every drug except for the JAK inhibitor, for tofacitinib. And so I mean, there's people in this audience who are much better at talking about this, but you know, inflammation is bad for cardiovascular and it's a pro-inflammatory state. So by reducing that excess, and we've seen that in the CANTOS study, we've seen that with methotrexate colchicine in people who haven't got inflammatory diseases, that reducing even low levels of inflammation is cardioprotective. And that, I think, is why the FDA are so worried about the tofacitinib signal, because it is going in a different direction to everything we see with our other immune modulatory drugs. Does that answer your question?
Yes, absolutely. Yeah.
Any other question?
Maybe could I also have a third one? You mentioned that TYK2 is an allosteric isoform. Do you think there is any possibility to explore and harness the allostery of TYK2 with other rheumatology drugs?
So I think that, you know, you wouldn't want to, you'd be cautious with other JAK inhibitors, but I think TYK2 might allow some of that. So I do think we will move to some sort of combination therapy in future, but rather than just me deciding to put two drugs together, it really should be driven by the biology, and that may vary from person to person. So I think there will be opportunities to modulate, you know, the small molecules allow that much more than we've had with the biologics. And so I think there will be real opportunities to fine-tune, which means we have to understand the diseases better to be able to do that.
Okay, so can I ask a very small question? So, especially, so I was impressed with some that so IL-70 blockade can inhibit or so does work on the psoriasis or psoriasis arthritis, but doesn't work for the RA, right?
It didn't. So there's a signal that IL-17 inhibition did help in RA, but it didn't meet its primary endpoint.
Okay.
And again, I think it's, you know that when we take cells and you put TNF on them, they go crazy. When you put 17 on them, hardly anything happens. You put both on, more happens. So I think it's the combination and what IL-17 does to TNF and other pro-inflammatory cytokines in rheumatoid. I think TNF is just too dominant, IL-6 is too dominant.
Okay.
So if you don't hit those, you're not going to do enough with IL-17. But again, maybe we can combine things in a clever way or use them in different orders.
But anyway, so that means the psoriasis and PSA and RA is a completely different symptoms, but it looks similar, right? So, so do you think, is it possible to, in future, to further differentiate the symptoms of RA based on the responsiveness of the various kinds of cytokine blockers? For example, RA type 1 or type 2 or something. How do you think?
And I think we're getting somewhere with the sort of the three big pathotypes that are coming out in the synovial biopsy. So no one's proposing synovial biopsy would be part of standard care. But if we can find, well, what is the blood biomarker, the liquid biomarker that it reflects what's going on in the synovium in RA, we might be able to stratify. And to be honest, we've got one stratification tool in rheumatoid arthritis, and it's as blunt as if you're rheumatoid factor negative, CD20 inhibition with rituximab is unlikely to work. And that's not a surprise. So in other words, if B cells aren't making rheumatoid factor, but we really haven't got stratification, so it's trial and error, and I think we need much better biomarkers, and we'll get better outcomes.
Okay, so, okay, so thank you again. Thank you. So the next speaker is myself. Okay, so I put this. Okay, so let's start. So again, I'm very happy to organize and chair this session. So on behalf of immunopharmacology section of IFUPA, so I'm presenting with this title. So this is a trend in the field of the drug discovery. So as you see, in 1970s, three major targets were infection, CNS, and cardiovascular. So since 1990s, oncology and so immunology and inflammation have been arising, and the proportion have been getting larger and larger in the 21st century. So now oncology is our first, and immunology is also in good position. So importantly, so there was a big change in modality in drug discovery, I think, such as the emergence of the molecular target drugs and biological agents, especially pharmacological development of therapeutic monoclonal antibodies have been achieved by the wealth of knowledge in immunology, and also contribute to the development of novel therapies against cancer and autoimmune diseases. So there's an example of molecular target drugs for treating rheumatic diseases. So this is relatively old data, and more drugs and pipelines are currently present. And among them, RA, rheumatoid arthritis, is a leading target for biological treatment for immunological diseases. So I'm a rheumatologist, and personally, I was deeply impressed with the great success of such kind of therapies. So from now on, so I will present some of my research topics. So as I said, I'm an original rheumatologist and seriously concerned on the inflammatory bone destruction in arthritic joints. So, and such bone destruction is mediated by osteoclasts, a special kind of macrophage having a capacity for destroying bones. But let's consider the bone destruction. So macrophages can engulf a pathogen or a death fragment, like here. So, and these are usually much smaller than macrophage itself. But bone is huge compared to the cells. And in addition, it is very hard and solid. So engulfing a pathogen, like eating bread for the macrophage, but so imagine if you're osteoclast, you're sticking to the wall and trying to destroy and eating them. So anyway, that should be a hard task. And then I wondered how they can do so. To understand the bone destruction event in vivo, I wanted to directly see the phenomenon in vivo and have originally developed a system for visualizing inside the living bones by using multiple microscopy like this. So here you see the migration of the macrophage in bone marrow species. So this was the first image showing the real cellular movements in living bones. So by further developing the system, we could detect the living mature osteoclasts on the bone surfaces. So here we conjugated GFP, green phosphoprotein, with a proton pump abundantly expressed in mature osteoclasts. This is the so important machinery for destroying bones. So we can clearly see the morphology and dynamics of bone dissolving osteoclasts. And based on the observation, we could distinguish bone-resolving R-type osteoclasts and non-resolving N-type osteoclasts in vivo. So by further developing, so the special chemical probe for detecting bone destruction in vivo, so we could see the actual event for bone destruction in vivo. So it was long controversial whether osteoclasts recognize something on the bone surfaces and specifically resolve only that area, or they just resolve or destroy all the areas they covered. So, so this is the in vivo image data. The red area represents the cell shape of osteoclast, and green represent the areas to be destroyed at this moment. So as you see, osteoclasts seem to destroy only a limited area on the bone surface. And now that, so we know the former model is correct. So since establishing the bone immune system around 15 years ago, I have been studying on the bone cellular dynamics and published several papers shown here. So although bone is a hard tissues, cells are actively moving inside, and imaging is a powerful tool for dissecting such dynamic systems. But anyway, a critical question has been arising. So I have been so far dealing with osteoclasts in homeostatic condition. Also, because I'm a rheumatologist, my major focus is pathological bone destruction in inflammatory joints. So, and I was wondering if these osteoclasts are really the same or not. So, and by our imaging technique, we could visualize both osteoclasts in physiological conditions and also in pathological conditions. So as you see, the cell shape are largely different. In pathological conditions, the osteoclasts become larger, and also so they are continuously dissolving bones without rest. And also, here you see the bone destruction event. As I said, in control condition, osteoclasts can recognize something on the bone surface and to be destroyed. But in inflammatory conditions, osteoclasts can destroy all the areas they covered. So their function is also different. So they look different, and the mode of function is also different. So then we wonder if these are really the same or not. And based on the question, we hypothesize that pathological osteoclasts might be different from those in physiological conditions. And by extensively analyzing ulcerative joints, we could finally identify a new macrophage subset specifically generating inflammatory osteoclasts. So this cell population is explicitly present in inflammatory joints, but absent in any other tissues or organs. So we named this macrophage as ulcerative osteoclastic macrophage, ATOM. So an ATOM is a unique macrophage only detected in inflammatory joints, inflammatory synovium. So, and also we further identified a transcription factor, FOXM1, as a critical regulator of ATOM cells. So in FOXM1 deficient condition, ulcerative bone destruction is clearly inhibited. On the other hand, bone homeostasis and skeletal development are kept normal in FOXM1 deficient conditions. So suggesting that FOXM1 is important for generating atom-dependent bad osteoclasts, but FOXM1 is dispensable for normal osteogenesis. So this is important information, and now that we can separate good and bad osteoclasts respectively, we can block only bad ones without affecting good ones by targeting atom-specific molecules such as FOXM1. And I think this will change the treatment for inflammatory bone destruction in future. So as you see, interval imaging is a powerful tool for dissecting a real phenomenon in vivo. In the meanwhile, I'd like to show that this tool is also useful for some pharmacological analysis in future. So this is a list I showed previously, and regarding the treatment for rheumatoid arthritis, there are three major types of biologics very currently used. One is anti-TNF, and the second is IL-6 receptor, and also the third is CTLA4 conjugate with immunoglobulin structure named abatacept. So they are all effective, but we wonder how they work in vivo. So for example, we test the effect of these biologics during in vivo observation of bone-resolving osteoclasts. So for example, in the case of anti-TNF, as you see, so R-type osteoclasts can convert it into N-type, so non-resolving types. So it was known that anti-TNF therapy decreased the number of osteoclasts when treated for a certain period of time. But now we know anti-TNF can quickly change the functional status of osteoclasts before they can reduce the number of the cells. So this effect can be very quickly seen. So similar effects can also be seen in the application with anti-IL receptor antibodies. So anti-IL receptor antibody can quickly convert into N-type, R-type into N-type osteoclasts. As far as observed with intravitreal technology, anti-TNF receptor blockade seems to be more effective for inhibiting bone destruction. On the other hand, abatacept has no such functions on mature osteoclasts. Even in the treatment with abatacept, R-type osteoclasts remain stable, remain active in R-type. So our similar results can be obtained with experiment using a chemical probe for detecting bone resorption in vivo, as I said. So both anti-TNF and anti-IL receptor antibody, but not abatacept, inhibits bone resorption by mature osteoclasts. So this is a summary. So dots in the left side represent R-type, and so dots in the right side means N-type. So as you see, both TNF and IL receptor blockade increase the number of M-type, but abatacept has no such effect. So nevertheless, I don't want to say that abatacept is not effective, right, for inhibiting bone destruction, because as we know, abatacept is indeed effective for limiting bone destruction in elderly patients in the real-world clinic. So how can we interpret the results? So I do not have enough time for explaining the detail, although I'm showing that abatacept can affect the migratory behavior of osteocyst precursor cells. So abatacept cannot affect on mature osteocysts, but can affect on their precursor stages. So we see that abatacept greatly stimulates motility of osteocyst precursors on the bone surfaces. So osteocyst precursors can differentiate into mature osteoclasts once they become stable on the bone surfaces. So in this case, abatacept stimulates the basal motility of osteocyst precursors, which should lead to the decrease in the resultant of osteocyst formation. And notably, this kind of function for mobilizing osteocyst precursors can be seen with abatacept, but absent in anti-IL receptor blockade and anti-TNF blockade. So this is a summary. So anti-TNF and IL-6 receptor blockade and also the abatacept are all effective for inhibiting RA as bone destruction, but their mode of pharmacological action are a bit different. So cytokine blockers, such as TNF blockade and IL-6 blockade, target the mature osteocyst status, whereas abatacept blocks rather osteocyst precursor stage. So I'm sure on the current update of clinical immunology, also I've heard that abatacept is relatively most powerful when used in relatively earlier phase of RA symptoms, which may be consistent with the current result, I think. Okay, so in addition to biologics, molecular target compounds such as JAK inhibitors have also recently emerging as attractive therapeutics in the field of immunology. or rheumatology. So we wondered what are the therapeutic points of action of JAK inhibitors. So in result, a JAK inhibitor is a ABT-317, blocks bone resorptive function of mature osteoclasts on the bone surfaces. In addition, this JAK inhibitor also modulates the migratory behavior of osteoprecursors. So, as I said, this mobilization also contributes to the blockade of osteoclast bone destruction in vivo. So, here we quickly check the molecular expression under JAK inhibitor treated conditions. In result, several key molecules controlling cellular dynamics, such as chemokines and sphingolipids, are changed by JAK inhibitor. So especially CCR1, a critical chemokine, chemical receptor controlling monocytic cells, are also regulated by JAK inhibitor. So concordantly, we also check that CCR1 blockade also controls cellular dynamics of osteoprecursors in vivo. So this is a summary. That is showed anti-TNF or anti-6 receptor target of mature osteoclast, and the CTLA-4 or Apocept broke the precursor status, and JAK inhibitor works for both. So, emerging JAK inhibitor has a great merit. Yeah. So in this case, because they works for both targets. Okay. So this is a kind of introduction. So this is a kind of summary slide of this part. So and here's a layer of the life science. So life consists of multiple layers, such as atom, the smallest, and molecule, a cell, tissue, organ, body. And recent advances in molecular biology propose a diversity of molecular targeted drugs, although we still do not know how they actually work in vivo. So I would like to say that intraoperative imaging is an attractive tool for identifying real points of pharmacological action in vivo. So the understanding of this aspect should contribute to the better or reasonable usage of different kinds of novel drugs, and also contribute to the future drug discovery. Okay, so let's change the topic a little bit. So besides bones, we have established intraoperative imaging like this. So bone, skin, gut, and lung, liver, or some other tissue. So as the system is dynamic, and imaging is a perfect tool for dissecting such dynamic systems. And in addition, we recently recognized that this kind of tool is also powerful for identifying unique cell types only visible in vivo. Especially, we are focusing on several tissue-resident macrophages in pathological settings because macrophages are plastic, easily can be transformed, and can be transformed. So depending on the surrounding conditions, like a chameleon. So they easily lose their features once they're isolated from the tissue. So then we have to see them in vivo. For example, we have recently been identifying a pathogenic macrophage inducing pulmonary fibrosis in vivo. So as we know, pulmonary fibrosis is a serious complication of rheumatic diseases with still poor prognosis. And we definitely need novel therapies against such diseases. In order to analyze what is happening during fibrosis, and we try to visualize the total course of fibrosis in vivo. So we use bleomycin-induced fibrosis model. This model is simple, and inflammation occurs in the first 1 week, and thereafter fibrosis change can be seen. So let's see the time course, and it's a control condition. So as you see, you don't see the, you can see the alveolar spaces, right? Here is the inflammatory condition here. And so please look at the day 9, where so the fibrotic change can be seen. So you see some characteristic large macrophage here, like here. So there are many stationary macrophage and big macrophage you can see. So, and this macrophage is only present in the onset of the fibrotic change and basically disappeared afterwards. So what are the macrophages? So, and we collect the macrophage from the rheumatic mice and then transferred into healthy mice. And then what happened? And we found that these large macrophages can directly cause fibrosis. So we are now further characterizing this cell type by single-cell analysis or something to find several specific molecules, and which become a good therapeutic target against lung fibrosis in future. So now besides bone and lung, we are currently identifying different kinds of unique cell types by using this kind of technology. So I'd like to emphasize again that so these cell types could only be found exclusively in vivo. So, and I think this kind of technology is also powerful for future, for finding a future therapeutic target in several diseases. Anyway, so this is a summary slide. So interbiotic immune system contribute to the immunopharmacology in at least two aspects. First, so we can detect the in vivo mode of pharmacological action of different therapies. So, and this kind of knowledge should contribute to the differentiation of emerging novel drugs. And so we now know the better usage or for treatment. And also, the second, so this kind of technology so have enabled us to identify some pathogenic immune cells which can exclusively be found in vivo. And so this kind of cell types or some related molecules should be a promising target for future drug development, I think. Okay, so it's time to stop my talk. And here's a member, and I would like to thank all the members and collaborators for their contribution, and also thank these funding resources enable us to perform this study. Okay, so thank you for attention, and happy to have some questions. Thank you. Yeah, please.
Lovely presentation,
Thank you.
I just love the intervital microscopy.
Thank you.
Could I ask you a question about the fibrosis model?
Mm-hmm.
You isolated the macrophages and then put them into other animals and they developed fibrosis.
Yes.
Yeah. Did you manage to, or did you look at treating the macrophages to prevent them from forming fibrosis? Because that would be quite interesting, I think.
Yes. So at the moment, we don't have any system for for depleting or for treating specifically this macrophage. We can't have. But for example, we have tested effect for example, the chlorinated liposome to delete all the macrophages in the lung. So, and we found that, for example, the chlorinated liposome treatment reduced or almost diminished the development of lung fibrosis. So that means macrophage cell types should be important for developing the fibrosis.
Thank you.
Please? Yeah.
Yeah. Mike Parnham, Epiendo. I'd just like to follow on from Adriano's question, because this is really a delightful presentation. It wakes us all up at this late hour of the day. Really wonderful. But following on from the fibrosis study, in transferring these giant macrophages. There are two possibilities I see here.
Mm-hmm.
One, it's products that they're producing that's stimulating the fibrosis, but macrophages, of course, are very plastic, and they can transform. Are they changing into fibrosis-inducing fibroblasts?
So we also have some experiment. We can correct large macrophages, and also we test co-culture with a large macrophage with lung fibroblast. And we show that the co-culture with a large macrophage induce fibrogenic property, or also lung fibroblast in vitro. So that means this large macrophage can directly induce the transformation of fibroblast.
Okay, thank you. And what are the surface markers of these giant macrophages?
We are now currently studying on that. Yeah.
Okay, and of course, in terms of rheumatoid arthritis, one of the major factors is that these giant macrophages are important for pannus formation.
Okay.
Have you considered looking at that?
At the moment, we haven't found such macrophage in the allergic joint. So, of course, there are many kind of pathogenic macrophage also in the allergic joint, but so these are macrophages are different ones from the we show in lung.
Okay, thank you.
Thank you.
Hi.
Okay. Go ahead.
Sorry. Lisa Stotts, as I have to ours. Really lovely presentation. I loved all the imaging. It's really cool. The different types of macrophages that you identified, the kind of the rheumatoid kind of precursor ones, the more normal ones, and the inflammatory ones.
Yeah.
Have you done any kind of sequencing or like kind of expression profiling to see, if there's any kind of, receptors or anything that are upregulated in some of those that might actually give us some new targets to actually selectively target those, the disease osteoclasts rather than obviously the normal ones?
Thank you for the question. So yeah, we have checked the expression of certain molecules in inflammatory osteoclasts and also the precursor we found, and also some inflammatory monocyte. Yes. So there are several molecules are differentially expressed, but at the moment we couldn't find any specific cell surface marker. So yeah, there are several molecules are changed, but we are currently studying on that.
Thank you.
Okay, so I think so let's move to the next topic. So okay. Okay, so next, check. Okay, so next are, okay, so from the, okay, so next speaker? So next speaker is Dr. Gaur, okay? So from India. So she's talking about 2B4 potential target in Staphylococcus aureus-associated allergic inflammation. Okay. Yeah, please start. You're ready.
Thank you. So, good afternoon, everyone. I am Pratibha Gaur. Today, I am going to talk about the work entitled 2B4, a potential target in Staphylococcus aureus-associated allergic diseases or allergic inflammation. First of all, before starting the presentation, I would like to thank WCP 2023 selection committee who gave me the opportunity to present my work here. So, Staphylococcus aureus, it is one of the most common human commensal gram-positive bacteria that occasionally becomes an opportunistic pathogen in skin and respiratory tract disorders. So when there is adverse effect, it creates a problem. We have previously, from the Francesca Levi-Schaffer's group, have demonstrated that Staphylococcus aureus and its enterotoxin activate eosinophil and mast cells via CD48 receptor, which is a GPI anchored receptor belonging to the slum family. Now, as the CD48 receptor is involving in SEB-associated diseases, there is a high affinity ligand for this receptor known as 2B4. So 2B4 and CD48, they both belong to slum protein family and as expressed on the membrane of most of the immune cells such as eosinophil and NK cells. These 2B4 receptor, as we can see here in the figure, it has two immunoglobulin-like domain, which are this, and a transmembrane chain, which is linked to the cytoplasmic tail. So these cytoplasmic tail, it has 4 ITSM, which is immunoreceptor tyrosine-based switch motifs. And we can see here that the SEP protein, which is a slum-associated protein, bind and phosphorylate here, which lead to further transduce the signal for the cell activation. Nevertheless, the third ITSM, which we can see here, is creating the inhibitory signal by adding the phosphatase, which can be SHIP1, SHIP2, and SHIP, and hence posing 2B4 also as an inhibitory receptor. So it seems the expression level of adapter molecule here and their availability and competitive binding define whether 2B4 will act as a activating receptor or inhibitory receptor. Therefore, we know from the group which already gave the name of the allergy effector unit. So mast cell and eosinophil are the main cell type for the allergic inflammation. Mast cell is expressing a receptor CD48. Eosinophil is expressing receptor 2B4. As I said before, the 2B4 is high affinity ligand for CD48. They are doing the collaboration and making the binding here. And this unit is known as allergy effector unit, which was generated from our group. So we know that these CD48 and 2B4 are sharing some structure similarities, as well as both are involved in the allergic inflammation. That is why we hypothesize that 2B4 could also be involved in the SEB-associated inflammation. To check our hypothesis, we first led to check that Staphylococcus enterotoxin B bind to 2B4 or not. For this aim, we exploited several various approaches. So first was to check by ELISA, where we have coated the ELISA plate by SEB and used a fusion protein of 2B4 at different concentration. We found that there is dose-dependent binding of SEB to 2B4. We have also checked this vice versa, where we have coated the plate by fusion protein and used different doses of SEB. We found there is dose-dependent increase and there is binding of SEB to 2B4, which we have proved by another technique, flow cytometer, where we have used the SEB, labeled SEB, and the BW cells which were constitutively expressing the 2B4 receptor. We found a shift here showing there is the binding of SEB to 2B4. Another method we have used is confocal analysis, where we see the co-localization of 2B4 and SEB, and 2B4 was associated with Alexa 594 and SEB was labeled. So it shows the co-localization only in the cells which were constitutively expressing the 2b4 receptor, not in the negative cells. These results were further confirmed by MST technique, which is a microscale thermophoresis, and we have proven after by using the various approaches that SEB was binding to 2b4. Now the question was, if so another, in collaboration, we have checked the predicted models of the SEB and 2b4. Just to point out, these are the predictions only, which always need to be confirmed by the validating by experimental modeling. So here we used human as well as mouse sequence of 2b4. So cyan color is for 2b4, and forest green and lemon color is showing the binding, the SEB, and these ABC is showing the binding site for SEB in 2b4. So in human sequence, we have 3 binding site for SEB, and in mouse, it's only 2A and B. Further, after having the proving the binding of SEB to 2b4, we have checked the functionality of eosinophil, this binding on eosinophil. So for this, we have used 2 different strategies to prove the eosinophil activation. First, we have confirmed by EPO release, which is an activation marker for eosinophil, where we, when the cells were treated with SEB, they were activated, releasing the EPO release. Although when we block the site of 2b4 on SEB, by using the fusion protein, we see a significant decrease in EPO release. We have further checked the IL-8 marker also, which is a pro-inflammatory marker, which shows a trend of similar pattern, although it was not significant. Another strategy to prove the functionality of this binding and interaction, we have used soluble CD48 on eosinophil, which was binding to 2b4 and blocking the SEB and 2b4 binding. And we see a decrease when a soluble CD48 treated eosinophil were activated by SEB. So it's significant in both the cases, EPO release and IL-8 release. So we confirmed and proved that there is functionality of eosinophil associated with this SEB and 2b4 binding. Later, to prove in vivo, we have used SEB-induced peritonitis model. We exploited C57 black 6 mice, wild type, as well as 2b4 knockout mice to check in vivo study. And in wild type mice, we had 2 groups. One was injected by PBS or SEB. Another was 2b4 knockout, which were injected by PBS or SEB. We have analyzed after 48 hours the analysis, and we found in 2b4 knockout mice, which were infected with SEB, in comparison to wild type, there is reduced inflammation occurs, which was confirmed by monocyte number, granulocyte, lymphocyte, soluble CD48 increase, as well as by spleen weight. So these are the inflammatory markers showing that SEB-induced peritonitis markers was less in 2b4 knockout mice. So to summarize the hypothesis, as I said, that CD48 is having 2b4 as a high affinity receptor. So when we again put some bioinformatic analysis and predicted the model of this tertiary complex where SEB, 2b4, and CD48 were present, so it was predicted that 2b4 is having separate site for CD48 and SEB, in case of human as well as in case of mice. Therefore, the current study demonstrated that 2b4 is an important receptor in SEB-mediated eosinophil inflammation and suggests a unique role for 2b4 in Staphylococcus aureus-associated allergic inflammatory conditions. At the end, I would like to thank Professor Francesca Levishafer, who gave me the opportunity to work on this project under the guidance of Dr. Mika Ben-Zimmer. And all the lab members and funding agencies, the Hebrew University of Jerusalem, as well as my current university, GITAM University, India, and the funding agencies who supported me to present my work in this conference. So just to announce for tomorrow that there will be very interesting talk by Professor Francesca Levi-Schaffer. It will be in the morning about the mast cell and eosinophil as new target for anti-asthmatic therapy. And we have, my two colleagues have presented a poster also, so kindly check it. Thank you all for your attention.
Okay, thank you, Dr. Gaur. So, have any question or comment? Okay, so you clearly show that so 2B4 or so HCB can bind to 2B4, so and that should deteriorate the so allergic inflammation, right? So basically, this interaction is bad for the allergy, right? It's a good or bad? It's a bad one, right? So what is the physiological or what is the meaning of this function?
So actually, there is always a balance. So here, 2B4 could be act as an activating or inhibitory receptor. What we are showing currently is inhibitory receptor. On the cell, which are related to allergic inflammation, is eosinophil. So we are saying if you don't have 2B4 knockout, you reduce, it could be used as a therapeutic marker as well in case of specifically SCB-associated allergic inflammation. That's true.
Okay. Any other? Nothing? Okay, so thank you very much.
Thank you
so let's
so
move to the next presentation. Thank you. So the next speaker is Professor Adriano Rossi for the University of Edinburgh. So the title of his talk is a therapeutic strategy to enhance the resolution of inflammation to promote tissue repair and regeneration. So please start if you're ready.
Good afternoon, everyone, and thank you to the organisers for the kind invitation. Looking forward to giving my presentation. So what I would like to do today is talk about potential therapeutic strategies to enhance the resolution of inflammation to promote tissue repair and regeneration. And what I would like to do is just talk a little bit about our strategy, how we go about our research. We use a lot of human primary cells, primary leukocytes. We do some preclinical animal models, such as a zebrafish tail fin. I'll come back to that in a minute, and also mouse models of inflammation, and increasingly samples from patients, and with the hope to go into patients with new strategies. As I said, we work a lot with human neutrophils. These little beasties are neutrophils. They're moving around. There's various arrows going in here that can activate the cells. There are various other molecules which can inhibit these cells. We're interested in how these cells get into inflammatory sites and how you can modulate that. The other process that we're really interested in is the process of cell death by apoptosis. And what you can see here is a neutrophil that comes in, touches those two dead cells, and then undergoes this active process of apoptosis. And again, there's various arrows coming in here that you can drive apoptosis, and driving apoptosis in a controlled, regulated way we think might be a therapeutic strategy, and I'll give you some examples of that. Various inflammatory mediators that are found in tissues can delay the onset of apoptosis, perhaps in keeping these cells alive so they can do their function. The other process that we're interested in is macrophage clearance of apoptotic cells. And what you can see, these are neutrophils being fed to macrophages. These two large cells are macrophages, which engulf apoptotic cells quite vigorously. And again, there are various arrows going in here. For example, you can enhance the clearance of apoptotic cells, efferocytosis, by glucocorticoids and various other mediators such as IL-10, lipoxins, resolvins, etc. And various inflammatory mediators can also delay that process or inhibit that process. When the macrophages recognize these apoptotic cells, they change their phenotype. They become less pro-inflammatory, they become more pro-resolution or even anti-inflammatory. And they do this perhaps by releasing mediators as well, which can help in repair of tissues and regeneration. What I would like to do is talk about some old data, some new data, and then some unpublished data. This is work that we did a while ago, and what we looked at was a number of compounds, small molecule inhibitors of cyclin-dependent kinases, and we spent a lot of time working out the molecular mechanism of action. But this compound here, roscovatine, is one of the family of CDK inhibitors, which are under investigation for various treatment of various cancers. But what we found was that these CDK inhibitors could promote caspase-dependent neutrophil apoptosis and eosinophil apoptosis. And what you can see in this, on the left here, are apoptosis. So neutrophils, when you isolate them from the blood, they undergo spontaneous apoptosis. About 20 hours of culture, 50% of the cells will be apoptotic. And you can see here that you can treat them with different agents. For example, if we just look at GM-CSF or LPS, you get neutrophils will survive longer, so you delay the onset of apoptosis. But in the presence of this inhibitor here, roscovatine, you see concentration-dependent induction of apoptosis. This is all in vitro with human cells. If you treat the cells with roscovatine, you get apoptosis. And we assess apoptosis by a number of different ways. Essentially looking down the microscope, counting apoptotic cells, or by an XN5 binding to apoptotic cells. And you treat the cells with this caspase inhibitor, ZVAD-FMK, which is a pan-caspase inhibitor, inhibits the induction of apoptosis, suggesting that this is a caspase-dependent phenomenon. So what we wanted to do was go into in vivo models of inflammation, and I'll talk about that. But this is just a little video showing neutrophils in culture. They're bathed in green annexin-5 and red propionamide. And you can see the cell here just kind of stops and then it blebs, and then it picks up the green dye on the surface. The annexin-5 binds to phosphatidylserine on the surface of the apoptotic cell, and the propionamide, because there's no macrophages to clear these apoptotic cells, eventually goes into these cells and eventually they become necrotic. And you can see all the cells become necrotic. This happy chap here is a neutrophil. It's jam-packed full of granules which are there, evolved to deal with invading organisms, especially bacteria and fungi. And this dead cell here is an apoptotic cell. And you can see that the nucleus is condensed, the granules are still within the cell, but it's become a bit more vacuolated. So this cell here is ready to be recognized by macrophages. So one of the first experiments we did, we said, okay, you've got an induction of apoptosis. Our hypothesis was that if you could drive apoptosis at the peak of inflammation, you might be able to resolve inflammation quicker. So what we did here was we used carrageenan. Carrageenan induced pleurisy. Carrageenan is derived from the Irish sea moss. It causes an inflammatory response. And we gave some animals carrageenan alone, some animals with roscovatine at the peak of inflammation, and some animals got the caspase inhibitor ZVAD-FMK. And what you can see here is when you give roscovatine at the peak of inflammation, you resolve inflammation quicker. This is edema, just a marker of swelling or fluid in the pleural cavity. And you can block it with the caspase inhibitor, suggesting that that resolution of inflammation is mediated by driving apoptosis of neutrophils in this case. If you look at the total number of cells, these are, which are mainly neutrophils, again, roscovatine enhances the resolution of inflammation. You've got less inflammatory cells, neutrophils in this case. The caspase inhibitor alone actually increased inflammation, which was quite interesting. So if you prevent apoptosis, you've got an increase in inflammation, and obviously it blocked the loss of neutrophils, that the increased number of neutrophils that you loss of neutrophils by roscovatine. If you look at the opposite, you can detect apoptotic cells, and roscovatine induces apoptosis, which again was blocked by roscovatine. And you can actually look at the tissue or the fluid, and what you can see in the control, there's lots of lovely non-apoptotic neutrophils, but in the presence of the CDK inhibitor, you get lots of apoptotic neutrophils or bits of apoptotic neutrophils located within macrophages. The next model that we tried, and we've tried a number of different models, and I just wanted to show you the ones relevant to this symposium. Here we used KBN serum, which is arthritic serum you can give into the animals at 2 time points. And then we decided in this particular experiment to give roscovatine at lower concentrations over a number of different days. And what we saw here was that the inflammation was reduced. Inflammation had already established, it wasn't at the peak of inflammation, but what we can see here is in the presence of roscovatine, you have a reduction of inflammation in the arthritic joint. I'm part of the respiratory group, and we were interested in inflammation in the lung, especially ARDS, acute respiratory distress syndrome. It's a disease where you get lots of inflammatory cell infiltrate, lots of neutrophils in particular. You have lots of swelling and edema formation, and there aren't any real pharmacological treatments for this particular disease, and mortality remains quite high, greater than 25%. So what we did here, we moved away from roscovatine. It's not particularly selective CDK inhibitor. So we used this compound here called AT7519. So we did all the pharmacology to show that it would drive neutrophil apoptosis in vitro. So these are just human neutrophils, increasing concentrations of the CDK inhibitor roscovatine or AT7519 caused a concentration and time-dependent induction of neutrophil apoptosis. It's much more potent than roscovatine, and importantly also prevented the survival of neutrophils induced by mediators such as LPS. So what you can see here, this is just an exon-5 binding, propionidine staining on the y-axis. With LPS, you have less positive an exon-5 stained cells, suggesting that LPS causes survival of neutrophils, but in the presence of the CDK inhibitor, you've got a massive induction of apoptosis. Okay, so that was in vitro. In the human system, we went into the mouse, and one of my colleagues, a PhD student at the time, he was interested in lung inflammation, so we gave IT LPS, and then after 24 hours, when you've got established inflammation, we gave some AT7519 systemically, and then we assessed inflammation. And again, what we saw here, this is just the control. You get inflammation, which does resolve. It's a resolving model, and you have lots of lovely neutrophils, mouse neutrophils here, and some alveolar macrophages as well. But in the presence of the CDK inhibitor, given at the peak of inflammation, you could enhance the resolution of inflammation. You can call it resolution interval, and you can quantify it. So essentially, CDK inhibitors given to this animal model, where you have LPS given locally into the lung, could be resolved quicker with a CDK inhibitor. We were interested in infection model, and again, so we developed this model where you gave IT E. coli live bugs at the peak of inflammation. Again, we gave the CDK inhibitor and then assessed inflammation. And what you can see here, the number of bowel neutrophils was dramatically reduced when we gave the CDK inhibitor at the peak of inflammation. Interestingly, given the CDK inhibitor at the peak of inflammation didn't overwhelm the animal with infection. In fact, we saw an enhanced clearance of the bugs, and we think that's because we've changed the macrophage phenotype to be better at clearing apoptotic cells. And it didn't have any direct effect on the bugs. And we're also interested in the molecular mechanism. We think that the CDK inhibitor is causing the loss of MCL1, which is a very powerful survival factor, a BCL2 family member in neutrophils and in eosinophils. And what we did here for this particular study, we took some cells from neutrophils from the blood from ARDS patients. We looked at them in vitro, we cultured them, and essentially the ARDS neutrophils survived longer than the control, age-matched, sex-matched individuals. But importantly, what we saw was an induction of apoptosis by the CDK inhibitor, even in these patient samples. And this is just some evidence that MCL1 is important. So what I would like to do is just, because keeping with the theme of the symposium, is just talk a little bit about an allergic type model. We had also shown that CDK inhibitors could drive eosinophil apoptosis. These are human eosinophils. Treat them with a CDK inhibitor and you get an induction of apoptosis. We had done some work to show that the AT compound could resolve eosinophilic dominant allergic inflammation. We also used this other compound called woganin, which is again is another CDK inhibitor, induces eosinophil apoptosis and attenuates allergic inflammation. We were interested in the molecular mechanism of action, and as I mentioned, MCL1 is really important as a survival factor in these granulocytes. So what we did here, we had an animal, a transgenic mouse, which overexpressed human MCL1. And what we did was we gave ovalbumin. We sort of primed the animal with IP ovalbumin at day 1, day 10, and then we challenged the animals further with ovalbumin, and then we harvested the cells. And essentially what we saw here was that if you had overexpressed MCL1, you have exacerbated allergic inflammation. And this is just the quantification here. The number of cells have increased, the number of eosinophils, the amount of protein, etc., has increased, the amount of mucus secretion has also increased in these humanized mice. And importantly, we could reverse this delayed eosinophil apoptosis in human MCL1 mice by the CDK inhibitor. And again, what you can see here is that the AT7519 could reduce the amount of inflammation that you saw once the inflammation had been established. And this is just the quantification. Again, you can see the inflammation is reduced with the AT7519. So that was looking at the apoptosis side. What happens if you interfere with the clearance of apoptotic cells? We had known for quite a while that glucocorticoids, for example, could enhance the clearance of apoptotic cells and possibly be via a mechanism involving some of these tyro3 and AXL1 MER receptors that are located on the macrophages. So what we did here in this study, we actually used MER-deficient kinase dead, or MER-KD mice, and we investigated the response to this allergic response in these mice. Again, we gave ovalbumin at day 1, day 10, and then we gave some more IT ovalbumin to challenge the animals, and then we harvested the samples after there. And what we found was that the resolution of inflammation was delayed if you remove these receptors which are involved in the clearance of apoptotic cells. And this is evident here. The resolution was delayed, and you could look at the histology here, and you can see clearly there's more inflammation going on here. We also did some functional studies. We looked at airway resistance by challenging with methacholine. Again, what we saw was that the MER knockout mice, which had less ability to clear these apoptotic cells, had enhanced inflammation in the airways, again assessed by airway resistance, by mucus secretion, etc. And we've also been looking at which cytokines are important in this model. It's quite complex, and we're still trying to dissect that out. What I would like to do is just move on briefly to talk about regeneration and it's actually quite difficult to investigate, and it was mentioned earlier on by Stefan about regeneration and repair is quite important. So what we do is we look at this zebrafish model. So these are zebrafish, and we look at the larval stages of the zebrafish. They don't have an adaptive immune system at this early time point up to day 5, or it's actually longer than that, but we investigate up to day 5 once they've been hatched. And what you can do here is you can manipulate the beauty of the zebrafish is that you can genetically modify these zebrafish to have green neutrophils or red macrophages. You can do intravitreal microscopy, which is quite nice. And then you can add drugs into the yolk sac of these zebrafish larvae, or you can add drugs into the water, and you can investigate various pharmacological approaches and genetic approaches. And essentially what we've done here is we've used this zebrafish model to look at CDK inhibitors. Actually, we're using this before we go into the mice. We might not even need to go into the mice, just to show that if you can enhance the resolution of inflammation by giving a CDK inhibitor into the water. And this CDK inhibitor was mediated by induction of apoptosis because you could block it with your caspase inhibitor, CVAD-FMK. And we've published a few papers on this model system. But the nice thing about this system is that if you, after 3 days of post-fertilization, you chop off the end of the zebrafish tail fin, after 2 days, you get regeneration. You can't really see it very clearly here, but you get significant regeneration. New tissue has come in here, and you can quantify it. And we're looking at what's really important in this regeneration. If you have a fish that has basically no macrophages, the regeneration is severely curtailed. So we know that macrophages are important. We also think that neutrophils are important, but it's much more subtle, and we're looking at potential mediators which might be important. So this is a zebrafish larvae. Remember, this is only about 1 to 3 millimeters long, and what you can see here, this tail fin is being cut. We have some green neutrophils. The green neutrophils come along, earlier time point, and if you wait for a bit longer, this is around about 10 hours now, the neutrophils start to disappear, either by reverse migration, which is a new phenomenon, I guess, and then the macrophages come in. The macrophages are these magenta color here. And what the macrophages do, they tend to form a wall to, I don't know what it's doing, to prevent further infection, to prevent damage by possible neutrophils, etc. So here you can see your neutrophils coming in, obviously dealing with the damage or potential infection, and here you can see the macrophages coming in, and this is a later time point, and they form this wall here, which is quite nice. So you can do lots of different experiments on this. These are neutrophils coming down. The zebrafish tail fin is facing that way. You have your neutrophils, and then you have your macrophages coming in, walling off the damaged tissue. And obviously you're getting regeneration going on here as well, but we don't really know which mediators are important, but that's just something that we're investigating. But just to finish off really, I want to just mention some of the work that we've been doing in the heart. So this green heart, let's see if I can play that again. This is a zebrafish that has fluorescently labeled cells that you can see the heart beating, has 2 chambers. And what we've done is we've actually caused a laser injection of the heart. This is a control heart. You can see here some macrophages coming in around, just patrolling this heart. And here you have a heart that's been lasered. Just a little bit of damage in the wall, and what you get is an influx of these macrophages. Which mediators are important for this macrophage accumulation? We're not fully sure, and this is something that we're investigating. So basically, this up here is macrophages coming in, so there's damaged heart. And you can see it in different ways. Interestingly, the neutrophil in this particular model seems to sort of prowl in the sort of perivascular site around the heart rather than entering the heart itself. So we're trying to work out what's going on here. We've looked at a number of different molecules, including our CDK inhibitors, selective CDK9 inhibition. So it's CDK9 we think is the target here. CDK9 resolves neutrophilic inflammation and enhances cardiac regeneration in larval zebrafish. So this is an area that we're investigating. So really, to summarize, is that we think that inflammation over time can resolve under normal circumstances. However, in chronic inflammation, it doesn't resolve, or it takes a long time to resolve. So you have non-resolving or inflammation. But what you can do is modulate inflammatory cell recruitment and activation to dampen inflammation. Or what you can do is promote apoptosis or erythrocytosis. And I showed you some examples of how that could be done. You could enhance apoptosis by CDK inhibitors, glucocorticoids, very classical anti-inflammatory drug, as you know, can enhance the clearance of apoptotic cells. And you can manipulate the response. If you actually delay apoptosis or decrease erythrocytosis or clearance of apoptotic cells, you can then prolong the inflammatory response. So the strategy that we're thinking of is to drive apoptosis where you know the cells are important, such as neutrophils or eosinophils, making sure that you clear those apoptotic cells. And we've not had any sort of model system where you overwhelm the macrophages by the number of apoptotic cells we have. And it's important these apoptotic cells send a signal to the macrophages to switch off and become more pro-resolution. And obviously, there's a lot of people involved in this, too many to mention, and I would just also like to thank the support that we've had, especially from the MRC in the past. Thank you very much.
Thank you for a very nice talk. So, please.
Thank you, Adriano. Very nice talk, as always. We know that all these things are occurring in the microcirculation, arteriolar, capillar, venal. But I think there is a system missing in this story, that is the lymphatics. What do you think? Are they useless in this story of resolution, or we are simply forgetting this component in the microcirculation?
That's a good question, Marco. Probably a bit of both. We're not investigating the lymphatics enough, but I think it plays a really important role in the ability of clearing the system from some of these cells and some of the mediators. But we haven't directly investigated the lymphatics, but it's certainly something that we should do. I know it's a difficult area to investigate, so that's possibly one of the reasons why we haven't. But good point.
Mike Parnham, Epiendo again. As usual, nice presentation, Adriano. I was wondering about the activity of your CDK inhibitors in your in vivo models. You're showing nicely that in the inflamed site, you're inducing apoptosis, the cells get eaten by the macrophages and you clear up the inflammation. You did mention in passing that you don't get an increased bacterial infection, which is quite interesting, presumably because it's a short-lasting thing. But what happens to circulating neutrophil counts? Do they go down? And is that an issue if you're, say, considering trying to resolve more subacute inflammation?
Yeah, no, Mike, that's a really good question. And some of these CDK inhibitors have been trialed in various cancers. And one of the side effects is neutropenia. And that is, we think, obviously from the bone marrow. I think we just get a reduction of the number of neutrophils that are being liberated from the bone marrow. We are thinking, obviously, of taking these CDK inhibitors a little bit further. We're looking at more specific CDK inhibitors, more selective CDK inhibitors. And what we want to do is to avoid that potential side effect, which I think is real, is to give it locally into the lung. So you would give a much reduced concentration of the CDK inhibitor directly into the lung, which would then get rid of neutrophils and without hopefully any sort of systemic side effects.
Okay.
Yeah, it's a good point.
Okay.
Adriano, nice talk,
Hi,
Stefan.
Stefan.
A really nice talk. So we've been trying CDK inhibitors in rheumatoid arthritis, with the theory being there's some refractory patients and it's the fibroblasts driving the disease. Do we know enough about the on the other hand, there's fibroblasts that are probably required for resolution, and they are the MOTK ones, the TAM ones you mentioned, it's a similar model, the receptors. Do we know enough about the selectivity of these CDK inhibitors to be able to target the chronic inflammatory side of say, fibroblasts or stromal cells, and not the resolution side?
Yeah, no, that's a good question. The way that we're going about this is we're looking for more selective CDK9 inhibitors, because we think the molecular mechanism in neutrophils and in eosinophils is by downregulating the synthesis of MCL1. And those cells are particularly sensitive to going into apoptosis because it gets rid of MCL1, and there are very few other BCL2 family members which can take over as a survival factor in those cells. However, in other cell types, they have perhaps other MCL1 or BCL2 family members which can override that. So we don't see much death in other cell types. It seems to be quite selective for neutrophils and eosinophils. And as for the fibroblasts, I'm not exactly sure how important some of these survival factors are in the fibroblasts, but it's certainly something that we should be looking at. Thanks.
Yeah.
Hi, Adriano. Thanks for the great talk. And I wonder whether the same idea that you mentioned about the macrophages can be extended to responses, for instance, when you have triggering by particles, in which they already will activate the macrophages, in the force, like silica particles or urates or things like that. If you can, you do have a very important neutrophil accumulation, but you have also the macrophages involved in trying to do phagocytosis of these particles. So,
yeah, no, it's a very good question. And, you know, talking earlier on about the bleomycin model, we've done a lot of work on the bleomycin model, but we haven't done the silica model. We are doing the silica model at the moment, and we're focusing on the inflammasome in those particular model, but we're planning to look at the silica model, and you're absolutely right. Obviously, you have frustrated macrophage eating of silica particles are not being cleared. What happens there? Do these macrophages get shut down and become less pro-inflammatory? So that's exactly what we want to try and do. But yeah.
thank you, Adriano.
Okay, so thank you again.
Thank you very much.
So, thank you. Okay, so let's move to the last speaker. The last speaker is Professor Moro from the Osaka University. So she's talking about the role of group 2 innate lymphoid cells in ulcerative colitis. So please start when you're ready.
Okay, hello everyone. I'm Kazuyo from Japan. And I first need to apologize that I submit my abstract with this title because I didn't carefully see what kind of session it is, and I brought today the story about the ulcerative colitis, but it is very interesting study, and I think many of people in the world have already known that how ILC2 is important cell in the allergic diseases, but this is very new story, so I think I hope you enjoy my talk today. So this is COI disclosure. So before we found this ILC2, people in the world thought that type 2 allergy is induced by T cell, especially Th2 cells, as shown here. So when the allergen come into our body, allergen is going to be uptake by dendritic cells, and this DC run into the lymph node, and educate T cell to Th2 cell from Th0 naive cell. And this Th2 cell go to the inflammatory site and produce type 2 cytokine and induce allergic diseases. But what we learned from ILC2 is without allergen, ILC2 can induce the allergic diseases. So usually the trigger is necrotic cell, which release IL-33, and this IL-33 is the strongest stimuli for ILC2. And once ILC2 get activated, they're gonna produce a huge amount of type 2 cytokine. And this huge amount is very important because compared to T cell, ILC2 can produce like 100 times more type 2 cytokines. So even this cell is small in the number, they can produce huge amount of type 2 cytokine. So, but today I'm going to talk about this cytokine IL-25, which is not well known on ILC. The role is not well known on ILC2. Anyway, ILC2 can be activated by so many different kind of factors in our body. For example, these are cytokines, and here is a lipid, and also neuropeptide is now known to induce the activation of ILC2, and also hormone regulation is very important on the activation of ILC2. And ILC2 produce so many different kind of type 2 cytokines shown here. And once ILC2 get activated, ILC2 produce the cytokine or express some molecule and affect on immune and non-immune cell, both cells. And I think people well know about the eosinophilia induced by ILC2, and this is one of the big topics in the allergy. But also ILC2 induce the mucus production by IL-13 production, and other cells are going to be affected by ILC2. So in the study of allergy, ILC2 always say that this is bad cell, but on the other hand, during the Helminth infection or viral infection, ILC2 have a good role. For example, in the Helminth infection, ILC2 produce IL-5 and induce eosinophilia, and these eosinophils can attack the worm, and mucus production is very important to wash out the worm from our body. And after, during Corona, people start working on the viral infection and reported that ILC2 produce amphiregulin or IL-13, and these cytokines both together have a good effect on our body because they can regenerate the destroyed epithelial cells and repair the tissue. So in the IL-33 knockout mice or ILC2 knockout mice, the viral infection going to be more severe. Anyway, so in the allergy, there's no enemy in the allergy, so this eosinophilic inflammation going to result into just a common inflammation and worsen the allergic diseases. So here I'm showing the whole picture of T cell related allergy and ILC2 related allergy. And now ILC2 is focused on the as a good target for the new medication. So anti-IL-5 antibody or anti-IL-13 and 4 receptor antibodies or anti-TSLP antibody have released and using for the new biotics on the asthma or rhinitis. And but today I won't talk about this, and would like to talk about the UC, which have done by Shun Hatai, who is a PhD student in my lab. So he's very funny student because when he joined to my lab, he said that he doesn't want to work on ILC2. So all the members in my lab are working on ILC2, but he said he doesn't want to work on ILC2, so I still don't know why he came to my lab. But what he said is he wants to clarify the true mechanism, how does UC occur. And so until then, I was not working on intestinal diseases, and I said, oh, we need to discuss a lot. And one day he brought this paper. So in this paper, this is very unique cohort research. In this paper, they're comparing the risk for the UC in the patient with appendectomy, or with appendectomy or without appendectomy. So as you can see here, the patient who got the appendectomy have a lower risk of the UC. And this good effect gonna disappear after 20 years old. So that means somehow, if we cut off the appendectomy, somehow the colitis risk gonna decrease. So he said he want to find out what is the mechanism for this cohort study. So we first need to make a mouse model on the appendectomy. So if we cut off whole so in mice, they don't have appendix actually, so it means a resection. But if we cut off this part, whole this part, mice gonna die. But he again and again tried the condition and changed the condition and cut off just top of this circum and made an appendectomy mice. So in this study talk, I would like to call this mice as appendectomy mice. Okay, so to induce the colitis, we use a common DSS drinking water. So first, we confirm whether the result of appendectomy in mice model show same as human cohort research. And we successfully made this model because this black line is with DSS drinking water. So as you can see here, the body weight gonna decrease and decrease day by day in the DSS positive control. But in this red line, appendectomy mice show better, lighter colitis compared to this positive control, which means that the severity of the DSS colitis was get lighter than the positive control. And as you can see here in the histology, we can see the crypt structure in the appendectomy mice, but in this positive control, the structure is fully destroyed. So these data collectively suggest that we successfully made a good appendectomy model to assess the role of the appendectomy in the colitis. So we found that the number of neutrophil is decreasing in appendectomy mice. Neutrophil is well known to induce, exacerbate the colitis, but the number decreased in the appendectomy mice, but the number of macrophage was comparable. And 3 famous cytokines which related to the colitis were decreased in the appendectomy mice here to here, here to here, here to here, which means that somehow appendectomy can reduce the inflammatory cytokine shown here. So we also compare the type 1, type 2, type 3 cytokines in sham-operated mice and appendectomy mice. And while interferon gamma and IL-17, IL-22 decrease in the appendectomy mice, somehow type 2 cytokine especially IL-5 and IL-13, increase in the appendectomy mice. So these three cytokines are known to exacerbate the colitis, but we're working on type 2 cytokine, so we focus on these cytokines. So to know what kind of cells are producing IL-5 or IL-13, we compare the number of Th2 cells and ILC2 before and after appendectomy. And when I saw this data, I was so happy because Shunya said that he doesn't want to work on ILC2, but this data suggests that he needs to work on ILC2, so this is my favorite data. Anyway, it looks T cell is not involved in this mechanism, but ILC2 is involving in this mechanism. And to confirm that, we made appendectomy mice in T-cell knockout mice and ILC2 knockout mice. So in T-cell knockout mice, the colitis didn't get better by appendectomy shown here to here, but the good effect of appendectomy couldn't seen in the ILC2 deficient mice, which means that ILC2 is involving in this appendectomy role. And so we first assess the role of IL-5 on this mechanism, but even IL-5 knockout mice or eosinophil knockout mice didn't show any changes in this effect. So we next focus on the role of IL-13 during this colitis. So IL-13 is most, I think, important factor to induce the mucus production. And in fact, the MUC2 expression, which is related to the mucus production, was significantly increased in appendectomy mice. So past staining also show higher mucus production in the large intestine. And it's a little bit hard to see this data, but we're staining bacteria and mucus and epithelial cells in white and green and blue, and trying to measure the thickness of the mucus layer, mucus barrier in the large intestine. And we got this data from this histological data, and it's showing here the appendectomy resulted in the thicker mucus layer, which means that the bacteria cannot easily come into the large intestine. So from these data, we found that by appendectomy, somehow the number of ILC2 increase and produce more IL-13, and this is going to result in the increased mucus production and suppress the colitis. So next question was, what is the upstream of ILC2? So, as I first mentioned in the introduction slide, ILC2 can be controlled by so many different factors, but the most famous one is IL-33, and I think next is IL-25 and also TSLP. So there were three factors which we need to assess, and so we first measure the production of IL-25 expression. It's production of IL-25, 33, and TSLP in large intestine, and only IL-25 was increased in the large intestine. So this data mean that IL-33 or TSLP might not involve in this mechanism. So it is well known that IL-25 is produced by tuft cell, a kind of the epithelial cells in the large and small intestine. And I think a biggest finding of this project is that we found that appendectomy resulted in the tuft cell hyperplasia in the large intestine. And interestingly, the number of tuft cells did not increase in the small intestine and only increase in the large intestine. So you can see the higher number in the appendectomy mice. And so that means tuft cell derived IL-25 might be a very important factor. So we check the effect of appendectomy in IL-25 knockout mice compared to the wild type mice. So here, the black line show the appendectomy mice in wild type mice. So it's not so severe. But without IL-25, with or without appendectomy, the colitis gets severe, which means that IL-25 is maintaining the intestinal condition, and I think making the thicker mucous barrier and protecting the intestine. But in the knockout mice, IL-25 knockout mice, the inflammatory cytokine shown here gonna more and more produce in the knockout mice. So this is an opposite experiment. We inject IL-25 into the large intestine directly, and as you can see here, the IL-25 injection cure the colitis. And this is a colon length, and IL-1 beta, IL-6, and TNF alpha expression was showing like this. And so these data collectively suggest that upstream of ILC2, tuft cell is producing IL-25. And it is also known that ILC2 produce IL-13, and this IL-33 can induce the tuft cell hyperplasia, not only for the mucus production, but IL-13 act for the expansion of the tuft cell. So we know this mechanism now, but still don't know why appendectomy can induce the tuft cell hyperplasia. So we wanted to know more upper stream of this mechanism. And because in intestine, all of the intestinal project, people need to assess something about the bacteria, commensal bacteria. So to check whether the commensal bacteria is important in this mechanism, involving in this mechanism or not, we put the appendectomy mice in separated with the sham-operated mice in this group, and in this group we co-house sham-operated mice and appendectomy mice to see whether the bacteria is involved or not. And in the co-housed mice, the effect of appendectomy disappear, which means that bacteria is very important for this role of the appendectomy during colitis. This is a data of inflammatory cytokine, as you can see here. In the single house mice, appendectomy can reduce the IL-1 or IL-6 production, but this effect disappear in the co-housed mice. And here, you can only see the normal structure of the intestine here in the single house appendectomy mice, but all other mice have destroyed epithelial layer. So, and we also count the number of tuft cell in the co-house mice. So in the single house mice, the soft cell increased, but it didn't in the co-house mice, which also suggests the commensal bacteria is important for this mechanism. So finally, we wanted to find out what kind of factor from bacteria is inducing the tough cell hyperplasia. So we collect the feces and check what kind of metabolites are changing before and after appendectomy. And here, factor X and factor Y, we cannot say the correct metabolite name because we are trying to apply to the patent now. But both factor X and Y were increasing after appendectomy in the feces. So we directly inject this factor Y and factor X, and only factor X show the good result from here to here, which means that this factor X is suppressing the inflammation and protecting the intestine. So in the factor X injected mice, we could observe the goblet cell hyperplasia from here to here. The number is showing here. And also, we confirmed that IL-25 production is increasing by factor X. So these data suggest that after appendectomy, eubiosis, which means that the bacteria condition is changing to the good condition. And one of these bacteria, we have already identified the bacteria, but anyway, that bacteria is producing one metabolite. And that one metabolite can induce the tough cell hyperplasia, and tough cell produce IL-25 and activate ILC2 and induce the goblet cell hyperplasia for mucus production and suppressing colitis. This is what Shunya have clarified. So now I'd like to stop my talk here, and this simple list of name is my collaborator for this project. I'd like to thank all the collaborators, and that's all, and I would like to take any question. Thank you very much.
So thank you, Dr. Moro, for a very nice talk. So is there a question from the floor? Okay, so please go ahead.
Thank you very much for the talk. I was wondering where exactly is ILC expressing in the colon with small intestine, and I know ILC2 is also expressing in other tissues such as lung or skin. Is there any different expression profile compared to other tissue, or like any cytokine production differences?
Yes, that's very important. As you know, ILC2 are tissue resident cell, and so many people are working on lung ILC2. But there is one beautiful paper published by Roxley's lab, and in this paper, they're comparing ILC2 from different 5 tissue: bone marrow, lung, skin, intestine, and fat tissue. And this data clearly show that bone marrow-derived and lung-derived ILC2 are IL-33 dependent cell. They are highly expressing TST2, which is IL-33 receptor. But intestinal ILC2 do not express high level of IL-33 receptor and expressing IL-25 receptor more. So I think this is making the big difference between intestinal and the lung ILC2.
Thank you.
So,
thanks for a great talk. I just want to know whether you'd looked at factor X and factor Y in human feces in relation to appendectomy and UC, because that would be a great story, wouldn't it, from a translational point of view?
Exactly. So that's what we need to do, but the number of patients who get the appendectomy is decreasing in Japan. I don't know in this country. And we still, we can find, but it's not so easy to do it in one university. And, but we are planning to do it. So if we could confirm this factor X expression in human feces, that would be very nice. Thank you very much.
Okay, so let me confirm. So the factor X or some other, so these are basically metabolite derived from the intestinal microbiota, right? Okay, so not produced from the host.
Oh yeah, so that's a very important question. We can detect this factor X from tissue sample in small amount. So I cannot say like immune, I don't know, immune or no immune, but our cells cannot, I'm not saying our cell cannot produce this factor, but compared to the production level from bacteria, the amount is very small and can ignore. And maybe to answer the second question I got, this factor is not well known, well reported factor, but we could find one paper on human colitis about the expression of this factor, and it was decreasing in the patient with colitis. So we need to confirm by ourselves, but I think we can, I hope we can get similar result in human.
Okay, so thank you again, Dr. Moro, for a nice presentation. So, okay, so it's time to close the session. So I cordially thank all the speakers for excellent talks, and also thank for all the audience for active participation. Thank you.